Good evening and welcome back to WBFO's Facebook Live studios. I'm Thomas O'Neill White, and this evening we are here to talk about vaccines, COVID-19 vaccines, health disparities, and race. With us this evening is Dr. Kenyani Davis, the medical director at the Community Health Center of Buffalo, and Dr. Raul Vazquez of the Urban Family Practice. Dr. Davis and Dr. Vazquez, welcome. It's good to have you both with us.
Thank you for having us.
Yeah, thank you.
Now, with the COVID-19 vaccine, a lot has been made about disparities. Dr. Vazquez, can you give us the latest numbers on vaccinations of Latinx, African Americans, and whites in the city of Buffalo?
Well, the numbers, they fluctuate. I mean, I think even the data that's coming out when we start to look at it, they're talking about across the state about 41% have gotten one vaccine, and we're getting fully vaccinated somewhere in the 30%. But the numbers for us are kind of not always where they need to be. So I'm curious to see what Dr. Davis's numbers look like, because they're so different. I look at it from we've given over 7,000 shots, and what we see is at least within our ratio, we're vaccinating more Black and brown. But it's not what I'm seeing across the state. So the numbers fluctuate. And I think they're deceiving sometimes in terms of not being able to touch the markets that are, especially the ones that are quite affected by the zip codes. So you want to tell them?
Absolutely. I agree with what Dr. Vazquez says. I think the notion that Black and brown people aren't getting vaccinated, it's not necessarily true. It's not having the vaccines in the right hands so the people who can get to them. Right? And it has to be intentional. We've given out about a little under 1,000 vaccines. We were a little late to the party because we chose Johnson & Johnson, which came out a little later. But we were very intentional about where we went, very intentional about the demographic. And I got to tell you that people showed up and they were ready. The hesitancy was real, but I got to tell you, a good portion of who we vaccinated as well were underrepresented minorities.
Now, this idea of the vaccine not being in the right hands, is that a part of racism within the medical field? Would you think?
Well, I think the problem's been is healthcare has been delivered in our communities through hospitals. And I think that's been a real problem. So when the state wanted to deploy vaccines, the first place they went to was the hospital. So they got allocations to distribute, but they do really well within the building. Anything outside, there's no medical neighborhood models. So they couldn't really, they don't have the critical mass. They don't really have patient lives attributed to them. Our systems, we carry anywhere from 15,000 lives and in some contracts, 30,000 lives. And the hospital, because we see their numbers, may have 2,000 lives. And so it's really hard for them to even carry that kind of a volume. We can run 500 shots a day, within our model, because we know the community, we know the patients, and you have primary care involved. I think that's the key in this whole process. There's a lack of primary care in our communities. And as a result of that, chronic disease management is not often being managed, which really affected COVID. But public health is very important. So is primary care in terms of, screening and preventive procedures. And I think that's been the bigger issue than anything. So the vaccines has just exposed the problem that we don't have enough physicians that look like the community really doing the service that the community needs. And so I think we've been much luckier in terms of, like, I gave 7,000 shots. Why? Because I know the community. I know who to bring in, and I prioritize who needed to come in first. I didn't go by the system of the state, because the state, what happened was the majority of the people being vaccinated were white. And so what I was telling our Black and brown brothers and sisters, like, listen, America's never created a vaccine that would hurt white America. So they're on the line. I think we better start getting a little smarter about this. And I think that often, I know it's not what you want to say, but it's reality.
Yeah. Thomas, you have Dr. Vazquez and you have Dr. Davis on here. There's no filter with either one of us.
I love it.
I absolutely agree with, what Dr. Vazquez is saying. I always like to say in the midst of this, when people ask me my opinion on this, COVID is a health, COVID is a health disparity put on top of a health inequity. And what I mean is there's a difference between disparities and inequities, right? Disparities are, are, are by chance, right? Inequities are unfair and unjust. They are rooted in systematic issues, right? Maldistribution of resources, kind of like what Dr. Vazquez is talking about, right? And also lack of diversity, right? And that creates and perpetuates some of the structural racism. All of that, especially when you take that on top of COVID, right? It could be anything. It could be COVID, loaded, rovid, COVID, whatever you want it to be, because these health inequities exist, right? You're going to see this time and time again. And I'm sure Dr. Vazquez can agree. We've seen this story play out 50 million times over.
And the other thing too is if you have good primary care and there's good chronic disease management, then those individuals did not get infected. They had direction. So we were able to know who was infected, social determinants of health. We know health literacy, which is big. No one talks about health literacy, but not everybody understands medicine at the same level. And so the translation is real important. And that's how you may use peer pressure for people that are on the fence to get vaccinated. So hesitancy, while it wasn't a big thing before, it's becoming more of an issue now. And since we're getting to a sweet spot of about, 44% of people vaccinated, we're still not at herd immunity, but we have to find a way to crank up. And we'll talk a little bit about what's the real number based on the mathematics that we're getting from COVID itself.
Now, why is 44% considered a sweet spot for you, Dr. Vazquez?
No, it's not a sweet spot. I'm just saying we're not at the, so there's an R0 factor that's often given to each of the viruses. So if you look at polio and you look at smallpox, one person can infect 5 people, okay? And COVID falls into that same model. So when it first started, it was what we call a Norton factor of 2 to 2.7. So within 5 to 6 days, you were infecting 2 to 3 people. Now with this mutant, this strand that changed, now it's at a 5.7, which means that within 2 to 3 days, you're infecting, 5 people. And so when you start doing the calculation at herd immunity, we have to get to 80% vaccination rate in order to make this effective. So early in the process, we were all saying 75, but as this infection gets worse and we don't get people vaccinated, that number percentage continues to go up. And that's what I'm worried about. So no, we're halfway there if you want to look at the math.
And this is where community healthcare groups step in, to kind of fill in the cracks where federally, they're kind of missing. Is that correct?
Yeah, and the other thing is we have to start doing the math. So we know the zip codes that were hit the hardest. So 14215, we had a lot of COVID there. So if we don't, but the vaccination distribution has not been equal across all areas of the county. So some counties are at 60%, right? And some zip codes are at 2%, 3%. And so if we don't start to kind of map out where the infection hit, then those individuals are going to continue. They're going to get COVID again with this new variant. And then we're going to be back to square one. So we have to vaccinate some of these individuals really quick. And that's what I'm hoping to kind of do. And I think that's what, the community health centers and urban family practice, and the Jerichos of the world, all these guys are trying to make sure that we can have some sort of an impact on those numbers. It's important now.
And I want to quickly circle back to the issue of disparities, more importantly, implicit bias and systemic racism, and how these factors play a role in medical care.
Yeah, I'm happy to take this one. What's so funny is about 2 weeks ago, the CDC, the Mecca said, you know what? I think structural racism plays a part in all of this. And this is 2021, right? And about 2002, there was this very interesting report that the Institute of Medicine have published that basically looked at health disparities, and said, do health disparities really exist? And guess what they found? They found out that they really did exist across all parts of life. From the beginning of life to end of life, there was a systematic difference in how minorities were treated in outcomes, right? However, the research failed to really call racism or race a social determinant of health. And to kind of level set what a social determinant of health is a social determinant of health is all of the non-medical things that contribute to somebody's health care or health outcomes. Somebody's health, 80% of it is social determinants of health. Only 20% of it is what Dr. Vazquez and I do in the room for 15 minutes every single day. A lot of somebody's health is based in their built environment, their housing, criminal justice system, food insecurity, housing insecurities, financial insecurities, education. We can keep going on. So when you look at COVID or you look at any other health disparity or health inequity, if you really want to start addressing those things, right? It's not in my office. It's out there dictating those 80% and ensuring that the people out here have the tools that they need to help address those for our patients. And that's important. And these implicit bias, which was actually found in that Institute of Medicine report, that implicit bias plays a part. People feel that. Race is a construct. When I first came on here, you see a black female. You don't know it's Dr. Davis until somebody tells you, oh, it's Dr. Davis, right? That's so important because that's the first thing that people see, and that's okay. It's what you do next is really what matters, right? And patients feel that, and there's already a mistrust in the community. So like Dr. Vazquez said earlier, where when we were talking about vaccinations and they were going to hospitals, right? Black and brown people already have somewhat of an adversarial relationship with hospitals. So now in the middle of a pandemic, we're telling you, you need to go there in order to get something, right? So this mistrust, this feeling of implicit bias and how people are made to feel when they encounter the healthcare system, the medical community, my community, we have failed. And that's the reason why diversity is so important, so we can start to help to break down those barriers and have vertical representation for our patients.
And where does a lack of health literacy and a lack of primary care, how does that build to a lack of trust?
Well, I think and I'll target this one. So I've been doing this for 30 years, and I think what the sad thing is I haven't really seen much things change, and as a result of that, it's all related to, like, we build hospital centers and residency programs around our communities. We're like cash cows. If you want to know what hypertension and diabetes affects anybody, you come into the Black and brown community and they're going to see all aspects of it. Why? Because it's revenue, resources. We're cash cows. I've always said we've got to focus more on the wellness component of it. We have to focus more on the prevention, and make people aware. Because we sit there and talk to people about losing weight, and we pass a menu. We don't provide exercise trainers or dietitians or nutritionists or a chef to teach them. And so you have hypertension. Well, doc, I don't eat salt. Ketchup, oh yeah, I eat ketchup all the time. So trying to figure out what the substitutes are and how to really live a better, quality of life. Because at the end of the day, we're getting affected. And what COVID did, because it affected coagulation, it formed clots all over the body. If you already have problems in those areas, you're going to have more problems. So as a diabetic, you already have problems with your vessels. Now you form a clot, you're going to have an issue. You're going to have a heart attack. You may die. And we saw that in the hospitals, people being left after being on a ventilator saying they're okay. They go home and they die 2 days later. Those things are important, affecting aspects of the kidneys, aspects of the lung, brain. And what the problem that we have is we're developing post-COVID syndrome. It's a disease. We've injured those organs with this stuff. Now we're talking a year or two. And now when you get COVID, in the beginning, it was COVID for 10 to 14 days. Now it's long COVID. Now it's 2 or 3 months. So, it's like, we really have to look at this pretty, with a different set of eyes. But all that has to do with just better primary care. And I think teaching people the right things. not having food deserts, making sure people get the food, a lot of things like the social determinants of health can reduce costs in healthcare by 50 to 60%. That's a big number. And so I just think if we do the right thing for people, the right thing's going to happen, at least in these communities.
And we are here with Dr. Kenyani Davis, Medical Director of the Community Health Center of Buffalo, and Dr. Raul Vazquez of the Urban Family Practice, discussing COVID-19 vaccines, race, and health disparities. If you have any questions, please ask through WBFO's Facebook page, and we will get to as many questions as we can. Dr. Davis, you just spoke of representation. Could you share a story or two of the times when people hadn't seen doctors of color before?
Yeah, I think, there's many stories, but there's three very important stories, right? The very first one came when I was a resident, right? New to Buffalo. And I got to tell you, this guy right here on this call, Dr. Vazquez, opened his house up to all, when I mean all, I really mean all of the minority pre-med students, med students, and residents, and finding that community and being able to see a collection of physicians that look like me was the first step that kept somebody who's not from Buffalo here to train in Buffalo. That was the first part. The second part was when I got on the floors. And I remember I was an intern, and anybody who's done this, interns, we know nothing. And I remember I came into the room and I was getting ready to take care of this 65-year-old lady, and she just started crying, and I'm freaking out because I thought maybe something was wrong and I was supposed to do something. But she said, "You know what, honey?" She said, "This is the first time in 65 years I've ever seen a Black physician." Look at that. She's never 65 years old. She's been in and out of the hospital and never seen a Black physician, right? And then the third part about it is, when I was getting finished with residency, and then I ended up coming to the community health centers of Buffalo, and I saw more physicians that looked like me, and I was able to help my community. I was in my community, and I saw what that meant. Not my skill set as a physician, but just my presence, what my presence meant. And that's so important. That's so important for our community. If we want to start to turn the dial on our community, we need to start growing our own. And it doesn't mean that you have to be a minority physician to take care of minority patients. That's not true. Your heart has to be in the right spot. And you have to really understand the community. You have to be able to talk to people, not at people, right? And health literacy, like Dr. Vazquez was talking about, is something totally different. You can be the most educated person in the world and not have the health literacy, right? That's an acquired skill. That's a cultural capital that's learned, that's hand down. And that's what I'm talking about, why that's important, because it starts to shed light on these implicit biases that, other people have. When I walk in a room, when Dr. Vazquez walk in a room, we temper conversations, right? Things that other people who don't look like, us want to say, they can't say because we're standing in the room, right? So it's representation is important. It means a lot for our community. It means a lot for our medical profession, because when you look at Black and brown physicians, it's less than 3% of the nation physicians, less than 3%. Just, it's my little spill on that. I get passionate, as you can see.
I can see that. Dr. Vazquez, do you have anything to add on top of that?
No. I think, people want people that look like them. And I think we, we forget how important that is. And I think, you have to see it to be it. I mean, she influences people around her, students that see that. Through my whole process, I've touched a lot of people's lives. And sometimes it's little things. It's not big things. I've touched people that, gave them directions. Now they're PAs, nurse practitioners. Some of my students that are now faculty, because I've been doing this for a while, and it's amazing, that I see. They'll say, "This is my mentor," and I say, "Well, he was my student." So it was just it's a good ride. I think seeing more of us and supporting each other and really creating a chain to kind of grow. I think it's real important. I think that we got to. So we're opening the door at the medical school. That's been growing. This year will be the largest minority class in the history of that school. But that took time building, and it took people outside to change that. The problem we have is not college. We're losing them at high school. So if we don't start doing something there, we can do all this stuff up here, but there's nobody that's going to come through that process. And so how do we begin to create a pipeline that's so important in order to be able to kind of fill the gaps. Because I'm getting old, you're still young, Dr. David, but I'm getting old. And, so I've got two daughters, that. One first year medical school, one second year. As soon as they hit their residency, I want to do more in terms of population health. I find myself that I could touch more lives that way. And the direct contact for me may not be what I want to do, but the whole bottom line is there's so much opportunity in medicine, and healthcare is an economic enabler. We create jobs, sustainable jobs, and the only thing, so three things change the community. And my father-in-law, Willem Gator, always told me three things. Couldn't figure what they are. So he says jobs, jobs, jobs. So if we can come back and do that within the community, we affect a lot of different things. And it's sustainability that these communities need to really change.
And we've got a couple questions from Facebook. I'll share this first one. Has the county reached out to share their vaccine supply?
I'll tell you from my side. In the beginning, I was out there, right? I was trying to. I applied in December to try to get some vaccinations. I couldn't. They started giving them to the pop-ups. So I was lucky because the pop-ups knew me. So they would say, well, I don't know how to do this. So we'll call Dr. V. So the fact that I did really well with that, I was involved with multiple pop-ups, but I could not vaccinate my patients. So at one point, I was on the vaccine hub and I just told them, listen, guys, I'm going to have to resign because I can't do this anymore. I don't mind helping, but I've got some of my old patients that are really like angry and cursing me out. Like I'm not giving them the shot, and I can't for legal reasons. If they give them to me for that location, I can't move them back to the office. So I got to that. Then I finally was able to get some vaccines. But I was probably the first primary care private practice physician to get vaccines. And I was giving them before they were actually made available. I was also fighting at the state level to say, listen, guys, primary care, we're the Marines. That's what we do. We vaccinate. We've been vaccinating since the beginning of time. And now not to be involved in that whole process and just having other systems like pharmacy and hospitals, it was almost a disrespect with primary care when we do it well. So you know how they have problems with the second shot and 5 million Americans aren't taking? Well, my return rate and my second shots are almost 98 to 99%. Okay, why? Because we're primary care offices. We have a bond, we connect, we schedule, we follow up, we provide transportation. We go beyond the things that are important that you're not going to get at the hospital or someone that puts these clinics or the pharmacy, because that's not what they do. They think that you just give a shot. They don't understand the total person and a lot of the stuff they're undergoing. Some have jobs, so we can't just say, well, you got to show up here. Otherwise they can't make it, for a lot of these shots. Dr. Davis, I'm sorry.
And
no, you're right. You're right. It was a struggle. I mean, I think the whole notion of kind of the vaccine rollout, I mean, there's a part of you because it's new and you realize that they want to be able to enumerate the entire population so they can monitor for side effects, but it was insane. I mean, how to try to even get the vaccine, rules would change, 2-3 times in a day. And it was really a struggle. And, like Dr. Vazquez said, you'd be awarded vaccines, right, for that particular site, but you have 20,000 patients over here that are your patients that are attributed to you that you can't even do anything for, right? Patients get really angry at you when that happens. We're a federally qualified health center, so we were blessed to have our allocations come from the federal government, which were a little less of, the loopholes. But it's still a challenge, day to day, though.
And this kind of speaks to your point, Dr. Davis, of the idea of availability is not connectivity. Could you expound on that a little bit more?
Absolutely. We have a concept here, that I speak of that access is not connectivity, right? Everybody thinks build the brick and mortar and they will come. It doesn't really work like that. You can build the brick and mortar, they'll come, but it doesn't mean that you connect with them. Right? It doesn't mean that culturally you're connecting with them or you're connecting with the needs, kind of like how Dr. Vazquez said about the social determinants of health. You're not supplying rides to people, right? That's what primary care does. We connect. to people culturally, socially. We meet them where they're at. They're not just walls, right? And that's a huge point that I think sometimes we miss in this conversation.
And once again, we are here with Dr. Kenyani Davis and Dr. Raul Vazquez discussing race, health disparities, and the COVID-19 vaccine. If you would like to ask a question centered on these topics, please go through our Facebook page, our WBFO Facebook page. So tell us, Dr. Davis and then Dr. Vazquez, tell us about what both of you have done and are doing with vaccine distribution and education. What message works? Emotion, facts, a little bit of both?
Truth, honesty, sincerity, all of that works, right? I think, I think one of the things, and, coming out of the gate, it was very important, for myself, as well as even my CEO, is we're not going to be the black face in front of it that just tells people, oh, just get it because, hey, we're black and we say it's okay, right? Without sounding so brash. People are smarter than that, right? You don't need to dangle a carrot. Our community is smarter than that. Give us credit. Give us the information we need to make informed decisions, right? So I think it's a combination of both. People people are smart. They know when you're trying to tug on their heartstrings to make them cry, right? Or push them. And really, you don't want to do that. You don't want anybody going into something with trepidation or not being informed, because that wouldn't be a proper informed consent now, right? But I think what works is honesty, right? Honesty works, and continuing to talk works, right? That's what we have found, and that's what we've been doing at CHCB, is making sure that we push the education piece. Education is so important.
I think for me, it was, so I was lucky. Back in 2013, I created GBAUHN. And so it was a care coordination model. And so I had resources, I had people. When COVID infection hit back in March, we mobilized 220 people, and we were able to get mobile units, do testing out in the field, and really touch a lot of people's lives. Out of 15,000 lives during that time, I lost one person. That's a lot, but it was just one person, because we were using data, we were communicating. I had our navigators really getting panels of 80 to 100 people and just walking them through the process. So if you needed to be tested through our apps, we knew how to set you up. We also did a lot of contact tracing in the background. So now there's that bond that developed. And then when finally the vaccine came out, because they already know what messages to talk to them about, not only did we blast it in different languages, because people forgot that there's a lot of languages that we speak in Buffalo. So we speak 18 languages, and that was a lot easier to kind of target. And the other area that I think we dropped the ball and I jumped on was the fact that when I looked at the vaccine distribution across the country, Native Americans only got about 200,000 shots. And what I'm saying is, man, that's a community that really doesn't fight. They're okay with stuff, and I wasn't okay with that. So we ended up getting them engaged and really doing a lot of things with the Native community. But the Black, Latino, and Native community are the communities that really got hit hardest. So it was a real important for us to kind of really focus, but really developing other types of models, and the health literacy and what Dr. Davis talked about is really touching people. We did a town hall within our system, right? And in the beginning, we kind of asked people, all right, what are your hesitancy? And all the questions that people asked, they all had. We had our pharmacists go through the whole process, describe the vaccine. Then we actually talked to them about all the questions they have: Tuskegee, Bell's palsy, infertility, all that stuff that came out. We described it. And then all 220 went through the vaccine. Okay, now some were, but the peer pressure got them through the process. Then we discovered that most of the symptoms were either pain at the site of the injection, unless you had COVID. If you had COVID, you have memory cells. And so when you got that shot, your body recognized it, and you were having fevers, muscle aches for a day or two. Motrin or Tylenol took care of it. But then we all went through the second shot. That was a little different. People felt tired and but it went away within a day or two. So everyone heard about that. And now they're going, no, I'll just take the first shot. I'm 91%, I'm good. I don't need the second shot. But it's just a journey of creating all these ambassadors. And I think once that happened, we infected everybody with knowledge. And I think once they started to see people that look like them, then there was that trust. Well, for me, I don't work for a hospital. I don't, I'm a private practice. I don't work for anybody. So I've been here for 30 years. I'm going to tell you as it is, right? I'm not too comfortable with the Johnson & Johnson because I was talking about the AstraZeneca, and it's a little bit different to kind of sell that story. If we give you a Pfizer and Moderna, it's an RNA. It's a protein mixed, covered by a lipid covering. That's it. We're tricking the body. There is no virus in there, right? Everybody tells us about infertility. I said, well, you know what? If you get COVID infection, you may get infertility. If you get COVID infection, you may have erectile dysfunction. Yeah, that happens if you get the COVID infection, but not with the vaccine. I mean, we got 32 million people that were infected with COVID, right? 571,000 people have died. Got it? So when you look at, we've given 200 plus million vaccines and we're not seeing anything. So you got to determine what bucket. Yeah, did we have a couple of bad outcomes with the Johnson & Johnson? Yeah, but look at the big picture, because this post-COVID syndrome, we're not talking about it enough, but it's going to be a major problem going forward because some of these things are not going to be reversible. And that it means, things with effects to the brain and lungs, kidneys, that some of this stuff is not irreversible at all.
Well, I'm sure, telling men they may get erectile dysfunction will have them doing a whole lot of things to avoid that. But
taking the vaccine. I'm sorry to say, but I use whatever I got to use to make them understand.
Dr. Vazquez, if you don't mind me doing this, I want to just plug April 30th, May 1st. Vaccine pop-up. I want to just put that up in the atmosphere. If you want to talk a little bit about that, please go ahead.
Yeah, no. So we have 1,000 Pfizer shots. Okay. The nice thing about it, we're trying to get the young population because we haven't targeted them enough, and they're getting infected with COVID, and we're starting to see deaths in that group. So now what we're going to do on those 2 days from 9 to I believe 3 o'clock is we're going to do 500 shots on the 30th. And 500 shots on the May 1st. And it's so important to really get the younger population vaccinated. The problem that you have is it's a different generation, right? They're the TikTokers. They're all this other stuff that we don't play with. So information overload with some of them can actually give them the wrong information. So, we're using peer pressure. We're also trying to use examples of people that have gotten the vaccine and some that have had COVID, because I think they got to understand that it does affect them also, and that long-term complications with infertility is a major problem. So it's real important for them to consider to get vaccinated.
And we've got another question from Facebook for Dr. Davis. How do you stress the importance of the vaccine to folks who are afraid for one reason or another? This person says, my apartment building has many reluctant folks, whether Tuskegee or not accessible because they are homebound and other reasons.
So I guess I'd answer this in 2 parts. People who have hesitancy, like I said, going back to education, right? What an emergency use authorization really is, right? And I think sometimes we forget. That word is in the world of myself and Dr. Vazquez. So we understand what an emergency use authorization is, but the rest of the public really doesn't know what that means. And what that means is that through the federal government, devices and medical devices and vaccines are basically oversought by the FDA. And it usually takes about 7.5 years to make a vaccine. But in an emergency use authorization, in a time like a pandemic where you don't have a gold standard, the FDA has a process called an emergency use authorization where you kind of push a vaccine through if there's no gold standard and it is an emergency. And this is kind of where we're at. Now, even though we push it out, it doesn't mean that it doesn't go through the safety phases, right? It still goes through those safety phases in which after phase 3, they can apply for that emergency use authorization when it's deemed to be safe. But you're in this sweet spot, this middle spot, where you start to increase your subjects, you start to increase your numbers, and then you start to see stuff happening, right? Usually with other vaccines, like a pneumonia vaccine or a shingles vaccine, it's already went through that. So the general public didn't see that, right? So I think it's really important to educate people on what that part means, because I think sometimes we gloss over that. But the second part to that, in regards to kind of being homebound, whereas Dr. Vazquez is focusing on that very, very important population, the young population, which are the TikTok generations, like my son. It's a very challenging population. At CHC, very challenging. But at CHCB, we're actually focusing a little on the other side, to the homebound population, right? The population who can't get out, the population who are stuck at home. And that's kind of been our focus now, because I think over the past few months, we all got the low-hanging fruit, right? We got all the people who were ready to take the vaccine, or the people who were in that pre-contemplating phase, that we just had to move them from pre-contemplating to contemplating to action, right? Now we're in the phase where these people aren't even on that spectrum, right? We have to get them on that spectrum. So I think that for this particular question, I think that being the biggest advocate for yourself and finding those vaccines, or other institutions like Community Health Centers of Buffalo, or GBAUHN, who are out here in the community who can actually help.
Well, the other side of it is, so you've taken your second shot. The CDC says after 2 weeks, if you're around someone that has COVID, you don't have to quarantine. Now, if you're at a restaurant with people that are vaccinated, it's comfortable. You can have people in the home now come if you're vaccinated. So you're going back, you're converting into normalcy. So you're on the way out. If you're still not vaccinated, you're still going to have to follow all these rules. And after the emergency authorization, I predict that it's going to become a mandate. Just like on the plane. If you're on the plane, right? If you work at a hospital, right? Try not to get vaccinated. If you're into school and don't walk in with shots, see if your kids are going to get into school. So all that stuff is really going to change. And if you're in a government environment or government, it's going to be the mandate. So I'm saying you can hold out now, but eventually the peer pressure is going to be, do you want to be on the unvaccinated line that'll be separated, slow, or the fast track? So if you're vaccinated, you'll be able to travel, do the things that you used to do, 2019 life, or do you want to be in 2021 with COVID, which is going to be a whole different way of living?
Absolutely.
Do you think there's going to be a comfortability moving forward with people who are vaccinated, that they're going to continue to wear their masks, even if they don't need to? I'm fully vaccinated and I still wear my mask everywhere I go.
Right. Well, the problem you've got there is we don't know whether the T cell effect of the so when you get the infection, you have B cells and T cells that are formed. The B cells are the antibiotic response, and that's what we've been measuring. Okay, the vaccine works; it's all doing it because it's going to really affect to kill the COVID infection when it comes in. But the T cells basically terminate anything, so you're not infecting anybody else. And the studies are coming out. And they're looking like that. So not only will you not catch it, but you're not going to give it to anybody else. But because the studies are not there, that's what we're telling people that are vaccinated: wear your mask. So you're using it to protect others, not so much for yourself. But once we hit that 80% sweet spot with herd immunity, I think we're going to revert to not having to use masks. And that's why I tell people, the sooner you get on board, the faster we're going to go back to some normalcy. But because if not, all these variants are going to change it, and we may need a booster in a year. But I think, and I've been pretty on target with all this COVID, is once we get to that level, I think the vaccination levels, while we say it's good for 6 months, it's going to be 9 months. And I predict that this will be a 2-3 year antibody response. We may not need another booster during that time. And that's just because of our experience with vaccines and what we've seen. Even though we don't know much about, we do know about polio, we do know about smallpox, and these all look alike in terms of how they respond to vaccines in terms of antibiotic and T cell response, what we see with all the patients that we manage. And I've been doing this for 30 years. So that's what I predict.
I don't know. I think these masks have become a fashion statement. So I done seen some masks come through this come through this office. So I don't. So even if the CDC says no, let me tell you something, them glitter masks aren't going anywhere for some people. But I do think that, like Dr. Vazquez says, the quicker we get on board, right, the quicker we can get back to some type of new normal, whatever that normalcy will be. There is going to be a period. There's going to be a 7-year period where we are going to be figuring all this out, right? You will have more vaccines that are going to come online. You're going to have some that require boosters, because here's the thing, viruses are going to behave like viruses, right? The more they jump from host to host, the more risk you have for mutated strains. And the more you allow mutated strains to happen, the more you can potentially evade your vaccines, right? So it takes about 7 years to kind of settle into wherever it's going to be at. But the truth is slowing down the spread for many different reasons, right? It's slowing down the spread so that, one, our medical community, we can catch up, right? 2, we can study and learn. And 3, we can really start to see how long these antibodies last. And, and truth be told, I mean, in the medical world, we wear masks all the time. So I don't think it's anything abnormal for us. I got to say, I kind of like my mask. So I don't know if I'm giving my mask up.
I can't stand my mask. No, I can't. No. I mean, I use it because I have to, but it's just, especially I've seen patients that come in with COPD and asthma. Try to put a mask on these guys. Heart failing. So there's certain groups that it's going to be very difficult. I mean, for now, yeah, but I think eventually, once we get more people vaccinated, we can get a little bit out of this. And yeah, masks are what we have to do. Social distancing important. We always says you want to be 6 feet apart or 6 feet under. You gotta decide which is what you want. So if you're not 6 feet apart.
So I'd like to hear from both of you. What's next in terms of vaccine distribution into communities of color and representation in the medical field?
I think targeted approaches, right? Targeted, intentional approaches. That's what's next, or that's what should be next. At least that's what's on our agenda, right? Is targeted, intentional, plan. So a lot of times when we talk about, getting, healthcare out to minority communities, it's an afterthought, right? It occurs after the disease happens, after the catastrophe happens, but it's putting it in the forefront as part of the conversation, kind of like how, both of us, have been doing since this has started. It's been a part of the conversation, a part of the plan. And I think that's really what's next for COVID vaccinations.
Dr. Vazquez?
Yeah, no, I agree. I think we have to start looking at data and make decisions off of data, not really kind of, because if we looked at the data, especially in certain sections, we would have known what services and diseases were there and really applied services to do that. I want us to be a dot in a system and we all get treated the same. I don't want this dot to, because it looks a different color, it's getting a different protocol. We should all be treated the same. And I think that's the only way that data is the new oil. And I think with AI and other ways of doing things in the community, we'll work on finding the best way to kind of manage people, but not as an afterthought. We're always an afterthought. And I think health equities and social determinants of health, hopefully this story that everyone's on the bandwagon on will actually create a change that I haven't seen in my lifetime. So I hope before I'm no longer here that I see something like that, because it's beautiful.
And we've got one more question from Facebook addressed to both doctors. Are there any traveling vaccine vans that can come to an apartment building and take care of the folks with disabilities and who are homebound?
So, I'm actually working on something like that with the vaccine committee. So yeah, because, it's sort of, and it's Black and brown populations that make a good portion of that. So we're trying to map out. So we're trying the kits with this approach, but we have mobile units. We're going to be, if we can't get them to a certain location, it's how to, but the only issue with this is Pfizer has 5 to 6 shots per draw, and then Moderna has 10. So we have to kind of map it out, whoever we sent out, and you have to, once you draw, especially the Moderna, you've got a 5-hour clip that otherwise you wasted that vaccine. And in the Pfizer, you have to constitute it. So it's going to take a couple of steps. So yeah, we want to map it out to kind of, because, you're talking hundreds of people, you're not talking thousands of people. And if you can really map it out, you can have more of an impact and really go, it's what we need to do, not what we should do. We need to do that.
And for us at Community Health Centers of Buffalo, that's our focus, is people with disabilities and homebound, which is why we chose the vaccine that we chose, because like Dr. Vazquez says, behind the scenes, there's a lot of logistical challenges. I mean, outside of even once you have the vaccine, either one of them, I mean, there's storage, there's draws, there's how many per vial, there's a window. So we chose Johnson & Johnson for our vaccine logistically, because it was a one shot and it was better suited for our community and our infrastructure. And so that is our focus, is disabilities and homebound right now. So I welcome whoever was on the Facebook to give us a call, and we'll be happy to map it out so we can get to your house. And I'm sure, I don't know, Thomas, if you'll put that out there, but if my shameless plug, it's 716-986-9199. And just tell them Dr. Davis told you to call. So when they yell at me because the phones ring, that'll soften the blow. But we would be happy to come out to the house. And I think what's so beautiful is you have two physicians, right? You have two physicians here who are working together to target a region, right? A forgotten group, right? You have Dr. Vazquez who's got his his pop-up for the teens to get to that. God bless you for that age group. Right. And you have us trying to get to the homebound. It's two physicians in a community trying to impact it. And I think that's beauty in its own right there.
Now, one more thing I wanted to ask you, Dr. Davis, how can we find out more about the Community Health Center? I know there's a documentary that's coming out or has come out. Can you tell us a little bit more about that?
Oh, yes, the documentary. We thought it was very important for us to document just our experiences, with COVID, because like Dr. Vazquez had said earlier, primary care, we have majority of the populations. When this hit, 80% of the actual cases were in the community. We were taking care of those. The 20% was in the hospital, and not to knock the hospitals by any means, because it was a very grave, situation, but we were all on these front lines. We were all fighting, and it looked different for all of us. And we thought it was very important for us to document that. And the producers did an amazing job of just putting together the documentary and the multi-layer effects of racism and healthcare disparities, and why it's so important to have primary care. And we released it last week, and it turned out really good. And I want to say it's on Buffalo State College, and the link is actually on our webpage. It's only 22 minutes. I absolutely invite everybody to see it. My story's on there, so it's always interesting when you're vulnerable like this. But it ended up being a really good documentary, and I just invite everybody to take a look at it.
And Dr. Vazquez, how can we find out more about your practice?
Yeah, so Urban Family Practice, we're located at 564 Niagara Street and also 1315 Jefferson Avenue. We are, the office number is 882-0366, sorry. And what we're doing is we're going to evolve. This coming year, we're going to become a beast in the area. So we're going to be stealing doctors, and we're going to be expanding primary care across all areas, especially the 14215. In addition to expanding my care coordination model, and we're going to be building sites to really change on social determinants of health, wellness areas. And that's going to happen this coming year. So our transformation will be one of the biggest, and we're also going across the state.